Thank you for the introduction, and thank you to the organizers and leadership, and particularly Will Ross for inviting me to come here today. I've been able to enjoy a little bit of Napa, or the Napa Valley. Anyways, what I want to do today is talk. I have what, 30 minutes? 30? Okay, so I'm going to zip through a lot of things here. So what Will asked me to do is really give an overview of what we have done, what we've learned, and what we're doing now in the Hudson Valley. So it's not strictly an HIE talk, but we will certainly talk about the importance of HIE and where it plays in the Hudson Valley. But I would say for this to be sustainable, you really have to address most or all of the things that I'm going to talk about. So Hudson Valley, why I think it's a good example is in the area we have rural settings, we have urban areas, have smaller communities, and then also we have large businesses. IBM has a very big presence in that region. And if you look at where we are in New York State, we're north of New York City, and we cover, these are some of the demographics and statistics. We cover 9 counties in New York, in the region. Population's about 2.5 million. And if you look at us, we range from the lowest per capita income in the state to the highest. The physicians we're talking about, it's just slightly under 5,000 at this point. 1/3 of those in the region are primary care. We have 25 hospitals in the region. And if you look at the PCP ratio to 100,000 patients, it goes from 22 to over 100. So we really span the spectrum in terms of healthcare and in communities and patient populations. And you're going to see that theme throughout this in terms of how we've tackled our different problems. The projects that I'm going to talk about here and the different organizations touch half of the practicing physicians in the region. And actually, that's probably higher than that now. But if you look at the stakeholder organizations, the 3 key stakeholder organizations that have driven this over the last decade, there is Think, which is really the community convening organization, bringing the different stakeholder groups together. There is MedAllies, which is the technology organization that has created some of its own solutions and also leverages off-the-shelf systems. And we'll talk about that a little bit. And then there's the physician organization, Taconic IPA, that has, again, probably over 90% of the providers in that organization that practice in the region, the 5,000 providers. And each one does something different, but it's very synergistic. So if you go back and look at what drove this, over a decade ago, probably actually around 12 years ago, the IPA, which started all of this, really changed. It was an at-risk or risk-bearing organization, contracting entity for the providers, and made a shift to try to really go at quality improvement across the region. And in doing so, we don't have any really integrated delivery networks in the Hudson Valley, but there was information coming out of integrated delivery networks that made us go and visit several across the country to make some decisions on lessons learned, best practices that we may be able to translate into an open community. So I'm going to talk about some of those pieces that we think are important. One, if you look at IDNs, it became clear that their common leadership and governance was important. They had a unified infrastructure, technical infrastructure. They were able to do transformation across all the care settings and have a fairly coordinated approach to that. The transparency, again, was across all care settings, and the data was easier to get at than you could in a community for driving the reporting and transparency. And lastly, when they wanted to look at different experimental approaches or innovative approaches to reimbursement redesign, at an IDN where you have the inpatient setting under your corporate umbrella, the ambulatory settings, all the different care settings, and the health plan, it gives you more opportunities in terms of reimbursement reform or redesign. So if you then take some of those things and say, how are you going to do that in an open community, you get to these things. Where you had the leadership and governance, you've got to form new organizations. That's where Think came in. You have to change some of the mission and vision and culture at the different stakeholder sectors, health plan, hospitals, providers or physician providers, practices, and also within those organizations. You can't lay one system, an Epic, across the whole region like you see in many integrated delivery networks, or one uniform system. So you have to have some kind of creative strategy when you're moving the providers off paper, when you're connecting the providers, when you're looking at analytics. How are you going to what kind of creative strategy are you going to use on technology? And that's what some of this stuff is here today on HIE. You have to, for transformation, what we did is what ultimately, and if you would have looked at this slide 5 years ago, we wouldn't have had these initials, but we believe the patient-centered medical home and now the medical neighborhood starts to get those are ways to approach those transformational efforts at the practice setting and across the different care delivery settings. On transparency, you've got to figure out some way that you're going to profile the providers. And then lastly, since you don't have one insurance carrier just for your organization, you have multiple payers, multiple insurance companies, you have to have a strategy that will bring them together for a unified or somewhat partially unified approach on the metrics and the reimbursement reform. Otherwise, you have 20 different things you're doing with each provider and you can't move anywhere. So those are the things that I'll talk about today and what we've done and a little bit of what we think about that. So the new organizations and changing organizations, I mentioned Think. It was founded in 2005, initially as a RIO. I think it has evolved from that. It's a C3, and it's really the organization that takes what's happening at a federal level and a state level on the policy side, and it educates the practitioners and the providers and the different constituencies about what's coming and how to start to translate that into real life work for those organizations. They play a strong leadership role. The executive director there is phenomenal in being able to find leadership that's respected across the community and getting them to come on board to help push the new, innovative, sometimes transformative ideas in healthcare, which is sometimes very hard to move off the dime. She's been able to, or Think has been able to try really translate from individual organization, individual cultures to a little bit within those organizations, a common culture across the whole community, as I mentioned, in an integrated delivery network. And lastly, that is the organization that has worked with the payers on one side in terms of crafting something that they will get consensus on to deliver for reimbursement reform, and that the providers will get consensus on to do enough to get that reimbursement. So really, shuttle diplomacy is what Think does on that. This is who makes up Think: the long-term care facilities, community health centers, public health, physicians, consumers, hospitals, payers, and employers. That's the constituency. You can see in your flash drive, you have some of these details, so I'm not going to spend a lot of time on all this. I'd never get through this whole talk, but you can see the board of directors. There are set slots for each of those 6 groups on the board, and then the committees to the right are the operating committees, and those are part of why Think is sustainable is it's got a very thin administrative infrastructure and really leverages the community and the committees to do a lot of the work. They get a lot of in-kind work. They've been functioning since 2005, very effective and very active. You talk about creative infrastructure and how we've done it. MedAllies was put in place. It spun out of this effort and is a for-profit organization. It's dealt with EHR efforts, health information exchange, and I also want to talk a little bit about direct, which we are very big on right now in terms of interoperability. So those are the three areas that that MedAllies tackles and works on today, and I want to talk a little bit about each of them. So we do act as the regional extension center, or at least part of the company, for probably, I don't know, 1,000, 1,500 providers or doctors in the ambulatory space in the Hudson Valley. There is very deep expertise, local expertise on EHR software. The staff that deals with the EHR side, and there's probably about 30 staff members that deal with about 1,000 providers in terms of implementation, training, and ongoing support, and pushing these systems to a higher level of usage. And that's what MedAllies does in terms of EHRs. Here is an example, or this is I think some testimony as to the efficacy of MedAllies. If you look at the Hudson Valley today and the ambulatory side, and if you look at what would be an eligible provider, as of now, 82% of the ambulatory physicians in the Hudson Valley are on certified electronic health records. By the end of this year, 10% will have adopted those systems, certified systems, by the end of the year. So by the end of this year, we're going to have over 90% of practicing physicians in the Hudson Valley in those 9 counties on electronic health records. And if you take a look at a breakdown of who isn't on them yet, in groups over 25, over 10, by the end of this year, all practices will be on electronic health records. If you look at the 3 to 10 range, about 70% will be on there by the end of the year. So it's really the solo and 2 doctor groups that are the ones that still are only about half on. And it's interesting because we do this yearly, and we call each practice, we find out the vendor system they're on, the version, we crosswalk that to the ONC list of certified systems. So that, these are definitely on these systems. But we've noticed that actually the numerator of the solo practitioners, 2 doc groups, the numerator of adoption is going up slower than the denominator in that group. So there are more docs that are either retiring, coming together as larger groups, or joining larger groups than are adopting at this point in that group. We track every one of our docs on meaningful use, whether they would be able to go for meaningful use or not, even if they don't have the adequate number of Medicare or Medicaid patients. Every single doctor that we have on EHRs, we track meaningful use. And this again is to show the level of how granular we are with EHR adoption. If we have a yellow box, that provider will get a call and we'll look at why they're slipping on that. If they're red, they will have a visit. And if we see something systemically across the region, we'll dig into that and figure out what's going on and have either webinars or some on-site classes or whatever to get at usage of these systems. Health information exchange, we've been running a health information exchange in the region for over 10 years. At this point right now, it's really a community record for lookup. So you got a longitudinal record there for lookup. We also use it in New York State. They use the regional health information exchanges kind of as a node for collecting information from hospitals. Ultimately, it's going to be ambulatory providers. And then from there, moving it from that node up to the Department of Health for multiple reporting. So we do public health reporting through the exchange. And then lastly, I should really change this from quality reporting to full profiling, and I'll talk about that in a minute. These are just the different data sources. Suffice it to say, we have clinical data from the EHRs and from the hospitals, and then we have claims data. We have the claims data from about half of the population, about 1.1 million patients in the Hudson Valley. We have their claims data that we aggregate across 6 health plans. talk a little bit more about that later. By this time next year, it'll probably be about 80% of the patients will be in our warehouse. So this is just a typical lookup for the health information exchange. So you can search a patient, look at their record. You can do a drill down to do a medication reconciliation, go more granular. So it's fairly typical health information exchange. I want to talk a little bit about direct because we're really moving very strongly in that area. I know that Dr. Kibbe will be talking about directtrust.org. Definitely take notes. We have learned that it's not just about the technology and the integration. As you connect these different HISPs or these different networks together, you've got to have a common trust fabric or else it will go no further than your domain, so it's very important. But the bottom line is, as we know, we're moving into stage 2 meaningful use, that it's very much of this is about interoperability. Sure, they're increasing the bar on usage of these systems and the clinical relevance of them, but interoperability is really going to become important. And if you remember our number, that we're going to be over 90% of adoption of electronic health records by the end of this year, I can tell you that as we get more and more robust usage and doctors get on these systems, they really want to be able to communicate with each other across their electronic health records. So for direct, that's how we're using it. We are using it as the way to create a linkage between disparate electronic health record systems. And the use cases that we have focused on is the at the time of discharge clinical summary. It's not a full-on JCAH discharge summary, but it has a reconciled medication list, reconciled problem list, and a lot of other pertinent information. And at the time of discharge, before the patient is even in the car to go home, or long-term care facility or whatever, that primary care doc or the primary physician taking care of that patient will have that discharge summary in their inbox that minute, and that's direct. We've also focused on primary care referral to a specialist, and from the specialist, the consultation coming back, so the closed loop referral. Again, sending that referral while you're seeing the patient in the workflow, the specialist receiving it at that time, so they understand if they need more information, they can get it ahead of time, why the patient's there. Talk to patients time and time again how frustrated they are showing up at a specialist and the specialist asking them why they've been sent, let alone not having the adequate information. Direct is really the opportunity for the provider to send it to the provider. When I practiced, the primary care physicians that sent to me knew what I wanted on most of the diagnoses that I would see a patient for. Docs know what other docs want. They can send the appropriate information with that referral, and direct really holds a lot of promise there. So here's how we see direct fitting in, and it's becoming more and more clear to us. We do not think that traditional health information exchange will go away. We do not think direct replaces traditional health information exchange. They are different. And here's how we're starting to see this play out. And I've got to say that with direct, we're very much still in a pilot, but as we're starting to use it in those transitions I talked about, we're seeing how the providers are using that. So if you look at the spectrum from acute care to more chronic care, we see the health information exchange as the place where in the emergency room, we've been running it for years. If we were to turn off our health information exchange, the ER doctors would be very upset. And those that see patients in the emergency room would be very upset. Those that see patients urgently on admission to the hospital, if it's not your patient and you can't go into your EHR and look them up, the health information exchange becomes very important. So ER or ED, urgent when you're on call, health information exchange, that's where it's used most often by the clinicians. We see direct becoming more part of the day-to-day workflow. When you're sending a referral, when a discharge from the hospital, the things that I brought up. Another place we're starting to see our health information exchange used a lot, and I'll talk about it in a little bit, is with our embedded care managers in our very advanced primary care practices, our level 3 medical homes, where we put embedded care managers. They need a lot of information, and they're starting to go to the exchange a lot. So though that spectrum is where we see it playing out. So let me talk about what we've done on transformation a little bit. If you look at the Taconic IPA, not-for-profit, has been around since '89. I told you it changed about 12 years ago, really a quality improvement organization. Our business model is we do get payment from the health plans for our quality improvement efforts, not from the doctors. We have some grant dollars, not a tremendous amount. Again, I mentioned the 5,000 doctors. In 2008, we launched our patient-centered medical home program, and in 2011, our embedded care manager program. So let me talk about those a little bit. We actually have over 400 providers that are level 3 NCQA recognized. It covers probably about 70 sites now. And as I said before, just like the Hudson Valley has from rural to urban to small communities, we have tackled everything from solo practitioners to 200 doctor groups, multi-specialty, single specialty, federally qualified, hospital-owned, and we purposely have done this to understand how to implement and deliver these services in different settings, and they really do vary. As I mentioned, they're all level 3 NCQA, and about 80% of the group that got recognized in 2010 is coming up for re-recognition. They're going through that now for 2013 re-recognition. And for those of you that are doing this, it gets harder that second time. NCQA has made it tougher. The embedded care managers, so we've got a special project that we're doing in conjunction with Geisinger up in our region, and we modeled this off of Geisinger's Proven Health Navigator system and their embedded care managers with a little bit of a flavor of what's going on at Mass General. They've got another program very similar, and so ours is kind of a hybrid, but we put these case managers in our highest performing level 3 medical home practices. And so let me talk a little bit about the case managers. They have to have a lot of experience. I don't know whether it's 10 years or what in case management. They have to be certified. Once they're hired, they go through, it's now I think about 3 months of training with the IPA training program. They then go out to Geisinger for either another 2 or 3 months at sites for a real practicum, and then they come back and they go into one of our training sites for another 3 months or so before they're released out to a practice. These, I would say, of all of our different organizations, everything I'm going to talk about today, these are probably the happiest of all of our employees. They really like what they do. It's tremendously gratifying, and they're very dedicated. The care managers they focus on the most complex and the least healthy patients. These are really what Atul Gawande talks about when he talks about hotspotters. And what we're going at is avoiding readmissions, and we're trying to really streamline the transitions of care. There's a big component looking at patient experience, and we're trying to really knock down the unnecessary costs. And we have some evaluations that are starting to show comparisons. The metrics we use on this is 125 complex patients for every care manager. There's 10 primary care docs to each care manager, so you can kind of do the math. We have they're on site. We have some central infrastructure support with pharma, social workers, and psych. So again, what we're trying to get at is the patient-centered medical home, and then moving this out to really connecting now, working with the specialists, working with the hospitals on transitions, long-term care facilities, and we're really starting to focus on the medical neighborhood. I got the 5-minute sign, so I'm really going to fly. I talked about reporting and profiles. We have 3 components to that. We have a quality component, a utilization, and a patient experience. I mentioned before that we have data coming in, claims data. We get it from 6 health plans. That's going to expand. We also get it from the electronic health records and from the inpatient systems. We also have an ongoing CG CAPS survey for patient experience. These are just some shots of what our reports look like. Just mention the patient experience. I think we're the only site in the country that's doing the NCQA survey that's doing, in addition to an annual, we're doing a rolling monthly, because we're really working at moving from annual reports to quarterly and then monthly reports for current feedback to the providers to make it actionable. Here's where we look across the community, across all of our different groups. And just one thing I want to point out on the left, we do pretty well on some of these areas, but on the left is access. I just have to show this one quote. This comes from the survey. So we're hitting not great, less than 50%, and the survey question is, a written comment, does this provider's office give you information about what to do if you needed care during evenings or weekends? Patient's response, no, I just go to the emergency room for that. So we've got a lot of work to do there. Anyway, that was an actual response from a patient on the survey. Anyway, so things you need to think about when you're doing these profiling is what your attribution logic is going to be. If you're doing this across multiple health plans, we've validated with RAND our utilization measures. It turns out there's only 4 that we can use that are valid. And you've got to decide how you're going to do your cost, whether it's going to be episode-based or total cost of care. Those are considerations you've got to put in on reporting. And then last, let me just talk about our reimbursement redesign. We've been at this for 10 years, multi-payer, multiple employers. We have a combination of a fee-for-service and then an administrative piece for patient-centered medical home, and then we're moving into gain sharing. So if you really look at our trajectory here, first, we hit the infrastructure. Second, we did the patient-centered medical home, put in the embedded care manager, looking at profiling of value, moving to value-based purchasing. So what we've really done is set up our providers. 3 of our groups just got ACO designation. The region just got chosen as one of 7 for the Comprehensive Primary Care Initiative with CMS, where the providers are going to get $20 per member per month for Medicare. Commercials are also part of that. For the administrative component, year 2, they start to do gain sharing. So these efforts, I think, set us up for this region being chosen. Lastly, we do have very rigorous evaluation through Cornell and RAND, looking at all the things I've talked about, and multiple publications that we've got, looking at safety, quality, cost. Last comment I'll make is for the key pieces. 1, if you don't have leadership across the community, you really can't get it moving. If you don't have an infrastructure strategy, you're not going to be successful. And lastly, if you don't have reimbursement redesign that incents this behavior and these investments, it will never sustain. So with that, I'll conclude, and hopefully I'm on time. Thank you.